Arthritis Unpacked is a patient education resource developed and owned by Janssen Australia. The content is created by Dr. Paul Bird with the support of Janssen. The information provided is for educational purposes and does not replace the advice from your healthcare professional. Always refer to your healthcare professional about current treatments, possible side effects, and other considerations. Paul Bird is an experienced rheumatologist and researcher dedicated to the expert management of patients with all forms of arthritis and rheumatic disease. As well as caring for patients in his clinical practice, he continues to undertake arthritis research with fellow Australian rheumatologists and international colleagues, ensuring he is up to date with the most recent medical advances.
Welcome to the fourth episode of Arthritis Unpacked, a podcast series designed to help you understand your arthritis better and help you get the best out of your treatment. Join me, Dr. Paul Bird, an arthritis specialist, which is also known as a rheumatologist, as together we unpack your arthritis baggage, helping you navigate the maze of arthritis terms and treatments. Arthritis without the jargon, arthritis made simple, Arthritis Unpacked. Today we're going to talk about psoriatic arthritis treatments. Let me introduce you to an important concept right away: relief of symptoms and prevention of disease. This is not my concept, it's a concept the asthma world uses all the time. Many of you would know people with asthma. They get short of breath and they use two types of puffers to help manage their asthma. One type of puffer is a reliever. That's like Ventolin or salbutamol. They get short of breath, they take some puffs on that and it relieves the shortness of breath. The second type of puffer is a preventer. This is designed to be taken regularly and stops the asthma symptoms coming on. These are things like Symbicort or Brio Ellipta. Now you will know people with asthma who use a preventer and sometimes use the reliever as well at the start of their treatment journey, but once controlled, they generally keep the preventer going and use the reliever only as needed if the asthma flares up. Let's take that concept across to inflammatory arthritis, and in this case, we're talking about psoriatic arthritis. The first thing that I need to do for that patient in front of me is relieve their symptoms. They need to live their life now. They need to be getting back to normal as quickly as possible. So the first thing I'm going to talk to them about is providing relief from symptoms. And I'm going to use relievers. They include anti-inflammatory medications like Nurofen, Voltaren, Naproxen, Mobic, just to name a few. And I might suggest some painkillers as well, like paracetamol. If the inflammation levels are really high, I might use a powerful anti-inflammatory called cortisone, either by tablet or injection. Cortisone, also known as prednisone, prednisolone, or panaficort, is used short to medium periods of time, days or weeks, to control the inflammation and give symptom relief. I'll do that to wrestle the disease to the ground while I work out which preventer is going to be best for you. So, relievers first, and usually at the same time, I'll start another medicine as the preventer, just like asthma. And once the preventer is working well, you won't need the reliever as much. Remember, relievers relieve the symptoms. The main examples are painkillers, non-steroidal anti-inflammatory drugs like Voltaren or Mobic or cortisone. Most people with psoriatic arthritis are going to need a preventer. The relievers on one side will help for a bit, but if I don't get a preventer on board, the psoriatic arthritis is going to come back when I take them away. So reliever on board, person feeling better, and then we put the preventers into the system. Let's talk about the types of preventers we use in psoriatic arthritis. In this episode, we're going to talk about broad categories to give you an overview. The preventer medicines in psoriatic arthritis fall into three main categories. DMARDs, or disease-modifying anti-rheumatic drugs. DMARDs are the most widely used and studied drug used as therapy for psoriatic arthritis. DMARD stands for disease-modifying anti-rheumatic drug. These have been around a long time, and rheumatologists will generally go to these first as they have really good proof that they work in a large number of patients. Let me name the three main drugs in this group. methotrexate, also known as methylblastin or Trexject, leflunomide, also known as Arava, and sulfasalazine, also known as Pyralin. They are all tablets, and they all take some time, anywhere from 6 to 12 weeks to do their job, so you'll need a reliever while they're getting on to doing their job. Sometimes we may use these in combination initially, for example, a combination of methotrexate and leflunomide to get a better prevention response for you initially. Let's unpack category number 2 in the preventers, biologics. Biologics are special drugs that target specific inflammatory chemicals that are being overproduced in patients with psoriatic arthritis. These are given by injection or infusion because if you take them in a tablet form, stomach acid stops them from working effectively. Most times, your rheumatologist will try a DMARD first for 3 to 6 months or so, and then move to biologics if the DMARDs aren't working. There are a few different types in this category. TNF inhibitor biologics. TNF inhibitor biologics work by targeting something called tumour necrosis factor proteins, or TNF. TNF is a protein that sends signals to your body, eventually leading to inflammation that causes swelling, pain and stiffness in the joint. By inhibiting or stopping TNF, these medications can reduce the inflammation. That's why they're often called TNF inhibitors or TNF-I. Some common TNF inhibitor biologics are adalimumab, one of the brand names is Humira, sertolizumab pegol, sometimes known as Cimzia, etanercept with one of the brands Enbrel, golimumab, also known as Simponi, and infliximab with one of the brands Remicade. Non-TNF inhibitor biologics. Some biologics work differently from the TNF inhibitors. These medications work on a different cytokine pathway. Cytokines are a name for the inflammatory chemicals that cause the inflammation in your joints. These blockers target cytokines such as interleukin-17 and interleukin-23. These are also important regulators of inflammation in some people with psoriatic arthritis. Interleukin-17 inhibitor examples are secukinumab, otherwise known as Cosentyx, and ixekizumab, also known as Taltz. Interleukin-23 inhibitors include guselkumab, also known as Tremfya, and one drug that targets both interleukin-12 and 23, which is called ustekinumab, also known as Stelara. All of these work by blocking specific parts of the immune system. All of these have the same goal, getting the immune system back onto standby where it belongs. Let's take a breath. So many names, so many options, but it's all designed to make sure you have lots and lots of options to get you on the path to wellness. You won't have to go through all these medicines. Your rheumatologist will guide you to the best combination for you. Let's unpack the final category of preventer medicines, the Janus kinase or JAK inhibitors. JAK inhibitors are a new class of arthritis drugs that treat psoriatic arthritis. They're also known as small molecule medications and they come in pill form. They are as effective as the biologics and are usually used after initial treatment with DMARDs. Your rheumatologist may even prescribe this drug before you try a biologic if he or she thinks it's the right option for you. Examples include tofacitinib, otherwise known as Xeljanz, and upadacitinib, also known as Rinvoq. Phew, that's a lot of unpacking. Let's just take a moment to review what we've gone through. Remember, treatment is designed to get you back to a state of wellness. One of the things that I say to patients with psoriatic arthritis is the aim of our therapy is to get you to the point that you walk through my door and you have no or minimal symptoms and there's nothing you can't do because of your arthritis. We set that goal early. That way we both know which bar we're trying to reach, and to reach that bar, we have to use medicine. And I want you to remember those concepts we went through. The concept of relief therapy, like anti-inflammatories and painkillers that relieve the symptoms, and prevention therapy that aims to turn the illness off and restore you to wellness. While to some it may be confusing that there are so many prevention therapies available, I think it just tells you how complex psoriatic arthritis is and also shows how far we've come in treating it. As you know, it is different for every person, and everyone requires slightly different tailored therapy, and we are blessed with many options. Certainly several more than when I set out to help patients with arthritis. Now, while the medicine's working, there's a lot that you can do to help. Diet, exercise, and reducing stress are all important parts of the treatment for arthritis, and we will discuss that in the next episode. I'm Professor Paul Bird, and this is a podcast all about arthritis. Without the jargon, arthritis made simple. Arthritis Unpacked.